advanced care plan is the general concept. Advanced care planning means firstly looking at who's going to be making decisions for you. So if you've appointed somebody, or if there's an automatic appointment in terms of next of kin, who that person is. And so you focus, the patient needs to focus on that. And then give that person advice, or the advanced care plan could be done by that person if the patient's incompetent. But the whole thing is, with advanced care planning, is who's making the decision, and then what are the values that should inform that decision. So it's generally giving guidance, and we generally make a distinction between an advanced care plan and that sort of subset called advanced care directives. Now, directives leaves the clinicians little choice. It tells them this is what you have to do, or this is what you must not do. And so on. So the whole thing then is whether we want to go with directives, which are kind of tying the hands of clinicians, or whether go with advanced care plans that simply give advice, which then can be interpreted by the person who makes the decisions. So that representative is guided by those values. So that in getting somebody to do advanced care planning, the real focus needs to be upon what are your values that should inform these sorts of decisions, because you can't really predict what might happen. The clinical circumstances will develop as they develop, and as you know, they're changing all the time in healthcare. So as somebody's condition develops, the clinicians need to be able to adapt the treatment to their circumstances, informed by their values. And that's what advanced care planning does. It sets those values down and has the person reflect on them beforehand, so they know what their priorities are, what the technical term is critical interests, the things that are really important to them, sort of lifelong values and so on. The difference is then with advanced care directives is that they may have a status in common law. We're not absolutely sure because there are no precedents, but the thinking is that they probably do. If they went to court, they might be upheld, which means that a clinician who didn't follow a directive could be in the same state you'd be in if you acted without the person's consent. The courts would probably look at it in terms of what the circumstances were. So let's suppose you had somebody with a predictable condition, a neuron disease. He was at an advanced stage of it. He'd been intubated twice when he had infections, and he said quite clearly, I do not want to be intubated again, having been intubated twice. Now, in those circumstances, I think a court would probably follow that directive. And if you broke it, if you then went and intubated him, then they might treat that as like an assault in terms of treating him against his express wishes. But it would really depend on how that was well informed. He'd been through it twice before. But somebody who issues a vague instruction along the lines of, you know, in these circumstances I don't want life support or something like that, I don't know that the court's going to uphold that because it's so vague. When it comes to applying an advanced directive, that is one of these clear instructions, then the clinician needs to look at what were the beliefs of the patient when they issued it. So what did they envisage? And are those the circumstances that now apply? In other words, you have to say, well, was it informed consent? Are what we're doing now, is what we're doing now what this patient envisaged when they refused this treatment? And is what they're refusing what they actually refused? And did they understand what they'd be refusing and its implications? One of my concerns in this area is that the documentation that's available often has these blanket statements and that patients can tick off, or their representative can, and they don't necessarily understand the full implications. One of the things that I've seen happen with a general practitioner is that she received a letter from, on a couple of occasions, from an acute care hospital here in Melbourne, saying that this patient, a patient in an aged care facility, was not to be readmitted to the acute hospital because the representative had ticked the box to say that life-prolonging treatment was not to be given to this patient. So in those circumstances, they said, well, they can't be readmitted to an acute care hospital. It's a horrific thing for a GP to receive because the hospital is in a sense your backup. If you want to change blood pressure medication, for instance, you want the patient monitored. There aren't the nurses to monitor the patient in aged care. So normally if you were doing something like that, you'd have them readmitted. Or if there was an accident happened and they were injured in some way and so on. There are a whole pile of circumstances where you might want to send them to an acute hospital and the hospital is saying they won't accept them. Whether that's binding or not, I don't know, but it indicated the implications of one of these documents. So I'm sure the representative in signing that document, didn't expect that the hospital will then write a letter like that. So, you know, there are lots of issues, I think, that are complicated when you get into directives. The best thing for him to do would be to discuss, because he was actually in a Catholic facility. It was actually in Bethlehem Hospital here, and he had expressed his view clearly to his own clinician, so that the clinician would know that, be in the notes. His advice should be in the notes, that the guidance he's given should be in the notes. So there's no problem with them following the guidance. And of course, something like that, it's quite an intrusive intervention. There's no problem with saying that you won't do that. Certainly from a Catholic perspective, we look at it in terms of two things: whether the treatment is burdensome, and so whether the patient might consider it overly burdensome, which is clearly what he did. He'd experienced intubation, didn't want to have it again. And the second thing was whether it's likely to be effective. So we talk about futility and burdensomeness. Futility means, and it gets misused a lot, but what it means in ordinary English is that it's ineffective treatment. So a treatment that would not keep somebody alive, or would not relieve symptoms, or would not slow down the process of the disease, that's ineffective. That makes it futile, and that's when that should be used. And then burdensomeness comes in when there's some problem with the treatment, that the patient would regard it negatively in some way, whether it's repugnant or painful or costly or difficult to deliver and so on. All of those things would make it potentially overly burdensome. And it's interesting really, the decision about futility is a medical decision, because it's about whether it's effective. The decision about overly burdensomeness is really the patient or the patient representative, because it's a personal experience of how they would encounter that treatment. It's very much a subjective decision, and it needs to be made either by the patient or by somebody who knows the patient and has their values and so on, because it can be a value thing. Well, firstly, they need to ask them, well, who would be making these decisions? Who would be implementing your documents and your wishes? Who's your next of kin, or have you appointed somebody? And if you haven't, perhaps you should think of appointing somebody. So that would be to go through that step first, because they need to be giving advice to someone they can identify. Well, somebody who's experienced, say, with chronic illness, would probably have developed a sense of the sorts of things that are too much for them. And so they may have a clear idea of the sorts of things they don't want to happen. There are also the sorts of things that they would like to happen. So if somebody's looking at their death, there may be people they want there, the people they don't want there. There may be music they want. They might want the window open. They might want, they might want to die at home if they can. So that can be a priority for somebody to get home if they possibly can. So to orient the medical treatment around making things so that they can be cared for at home. And that can involve a different set of treatments than you might have if you were going to care for them in hospital. So you're trying to make them more autonomous in the sense of what can happen at home. Somebody who's been chronically ill will probably have clear ideas about a lot of those things. For someone who's not experienced illness and so on, it's much more difficult. And obviously that choice of who will represent them is very important, somebody who knows them well, because they'll need to respond to circumstances that they haven't yet experienced. And so it's very hard. But in general, you want their values. So if somebody is of a particular faith, you want to know that. If they want you to talk to somebody from that faith, for instance, get advice from a chaplain or something like that, then that they can express that. So there are a whole series of questions that you could put to elicit those sorts of responses. And I think the new document that from the CHA on this provokes those sorts of questions, the sorts of things that you go through with somebody and get them to answer what their priorities are in different areas. You come to sort of crossroad moments in treatment, whether you start something, whether you end something. You've got somebody who's dying, and they might need to be, there's a question about feeding them, or they might go into renal failure, there's a question about dialysis, and so on. So those are crossroad moments, whether you initiate something or you stop something. And to have that guidance is really very, very helpful. It can take the pressure out of that situation and really help with dealing with the family. You can say to the family, well, we had these discussions and she said, and these were the things that she wanted done in those circumstances. So, it can be really, really helpful to have had that discussion. And it's also very settling for somebody to have gone through this process and to keep going through it. It's not a once-off process, but to keep looking at what their advice is as they experience illness. A directive sets it in concrete at that moment, and then you can revise it again later, but it's set there, and there's an absence of flexibility. And it really it's likely to create problems for everybody. Problems for the representative because they can't adapt to the circumstances. Problems for the clinician because you might have wanted to have said some things to the patient that would influence this decision, and you can't. You've just got this directive set in concrete. That when people are facing death and so on, the family events that are going on at the same time matter. So if there's a wedding about to happen in the family, or if a baby's about to be born, the idea of giving general advice and values and so on that can be applied by the representative and the clinicians in the circumstances is much better and more likely to be in accord with that person's wishes. The substitute decision maker has an obligation to act in the patient's best interests. So they're not speaking from their own perspective. They're speaking from the perspective of what's in the best interests of the patient, but they still have moral and ethical obligations. So they have the same obligations as the patient. So from a Catholic perspective, we talk about stewardship. We don't own our own bodies, and so the representative doesn't take over the ownership of the patient's body. The representative is a steward of the patient, in effect, the whole patient. And so that they're guided by the patient's values and beliefs. They ought not take on the role of representative if there was likely to be a conflict between their views and the patient's views. So that there does need to be some congruence between the patient's beliefs and the representatives in that respect. So you couldn't take on the role of representative if you had a real conflict. But the important thing there, though, is two things. One, acting in the patient's best interests, and that includes being guided by their values and beliefs. And then secondly, acting according to your own moral understanding of what should happen here in terms of stewardship. So you're carrying out the patient's obligations of stewardship. So nobody's obliged to do everything to keep themselves alive, but they are obliged to do reasonable things to keep themselves alive. We've got to look after our health and life, and that applies right through, and that applies to the dying process. I mean, we can die well or we can die badly, and one way to die badly is to try and control it. You know, either control the timing of your death or to demand treatments that are not going to be effective, and so on, put burdens on other people and all those things. So, you know, there's a rich way of dying in terms of your relationships to others, of accepting being a burden to others, because it's the time of life where you will be a burden. It's just the way the cycle of life goes. So that there's no point railing against being a burden or railing against and so on, against the illness and disease. I mean, so dying well means accepting the human condition. It means accepting that I am dying, and you know, there are decisions to be made about treatments, and at some point, for these days, for most people who are dying, there will have to be decisions made about whether they have that last round of chemotherapy or whether they, you know, are to be resuscitated or not, and so on. So that for a lot of people now, these decisions have to be made. Otherwise, you die under the full force of everything that medicine can do. You die with somebody thumping on your chest instead of being allowed to die peacefully. These decisions can be very hard, and choosing somebody who's very close to you might not be the best decision. Somebody who's very much emotionally caught up with you might find it very, very difficult. It's a really difficult thing to make that choice about who should make decisions for you is really difficult. And you might choose one person to make financial decisions and a totally different person to make decisions about your health and life. You also need to set goals for communication. When I chaired the government committee on the unresponsive state, we've set these things out in a kind of formulaic way. But you need to look at, when you're making a treatment decision, you need to also be looking at how you're informing the representative and the patient, and how that process is going to go on, because people don't absorb the information in one hit, it's a protracted process, and you need to keep coming back to it using different language, because often the terms that are very familiar to clinicians are not familiar to patients, or they know the term but they get it wrong. You know, one of the things I found interesting was even the word clinician or clinical. For a layperson, clinical means something done in hospitals and you know, medical and all those sorts of things, where clinical for a clinician means actually dealing with the messiness of a patient, and it's the very opposite of the meaning. The terms that are used are really important, and one of the things to do with communication is to ask them questions. So the clinician should ask questions to find out whether they understood. Very simple questions like, what's wrong with your mother? What treatments are we giving your mother? Why are we giving those treatments? What do we expect the outcome to be? We had 4 questions in a study that we did at St Vincent's using the registrars to do it, and they were basically the questions. You ask those questions as a clinician, and you'll suddenly find usually that the answers are not complete. They haven't got the things that you thought you'd explained really well. And so you need to keep asking those questions, and you need to ask it not only of the one person, but all those people who are around the patient. Using the language of futility and burdensomeness is very helpful for people in their grieving afterwards and so on to accept that this was the right thing to do. And I'm not responsible for my mother's death. She died because she had whatever the condition was. And we could have kept her going, but only at this sort of cost. Once you put it in those terms, it makes sense, and it's easier for people to make the decisions. I often get calls about resuscitation from family members. Now, they may not be the family member actually making the decision, so they might be a bit distant from it, or they might be the person who's actually in the gun. But for the person who's a little distant from it, they can see a resuscitation decision and feel quite angry about that. They can feel that they've made a decision to end my mother's life or father's life, or my brother's life, and feel very strongly that the wrong thing is being done here. Partly because they may have what's called a vitalist position, that they think that everything possible should be done to sustain life. Partly perhaps because they can't accept that the person is dying when they are. And also partly because people generally have a misled idea from the media, from films and so on, that resuscitation works. Mostly resuscitation does not work. So mostly it's futile, especially where you've got a chronic advanced disease process that's caused the heart to stop or the breathing to stop. You're not going to be able to restore it because the disease process is there. It's got to that point. Resuscitation works when you've got some kind of trauma. Somebody gets bashed or drowned or something like that, and then you've got an event that you can try and reverse. But people don't, when they're looking at somebody in an advanced state of disease, they don't realise that. They think that if you put up a not for resuscitation order, that you're condemning them to death. And what you're saying is, now resuscitation involves several things. It involves intubation, so a tube put down into the airway. It involves cardiac massage, so thumping heavily on somebody's chest. It can involve defibrillation, you administer electric shock to resettle their heart. And there are drugs that are given. There are drugs given to affect the heart rate, like adrenaline, and there are drugs given to make them forget if they do survive, so they don't remember anything that happened, because it's also traumatic. It really is traumatic to be just intubated, and I've had the experience. And resuscitation is not to be taken lightly. With elderly people, frail people, very often they'll crack ribs. And so you've got somebody dying, and then you inflict all this hardware on them. The intubation, the chest bashing, the electric shocks and so on. I mean, I don't think anybody wants to die with that happening. And so the question for the doctors is, when we see that somebody is dying, their disease process is progressing towards death, we know that an event like this is likely to happen sooner or later. They'll stop breathing, or the heart will stop. Do we do everything right at that point, or do we say to the nurses and those caring for this patient, when they arrest, we're not going to do those things? And you have to be careful with this. You have to be really explicit when you're issuing this sort of instruction as to what you mean exactly, because you could have somebody who you're expecting to progress towards cardiac failure or respiratory failure, and then they swallow something the wrong way and obstruct their airway, something you can clear really easily. You don't have to intubate them, do anything else, you just need to clear the airway. Well, obviously you do that. So your instruction not to resuscitate or not include doing something basic like that. So it needs to be very clear. The other thing that's a danger is often when a not for resuscitation order is issued, people will, the caring staff can say, oh, well, this person's dying, so there's a sort of sense in which it becomes a self-fulfilling prophecy. And that can be a real danger. So that, they sort of say, well, the doctor expects them to die, so that's pretty much what should happen. And you can see, and I know from the experience of GPs in aged care, that they'll say that the nurses will demand that we up the pain relief, not because they need more pain relief, but because, well, they should be dying. So there's a sense that this is, and palliative care instructions can do the same thing. If you say somebody's for palliative care, that can mean they're not for anything else. When in fact, palliative care is about relieving their symptoms. Whatever else goes on with their treatments, their blood pressure medication, their antibiotics, whatever else is happening, those things should continue. You're not saying, we want this person to die, so therefore we'll orchestrate it. But that can be the meaning for both a palliative care order and a not-for-resuscitation order. So really important to be clear what they mean. They mean that we're not going with not-for-resuscitation, we're not going to inflict these extreme things of intubation and the rest of it. But we will do the ordinary things to keep somebody going, and the nursing care and all the ordinary things that are needed to keep somebody going. If somebody's in an advanced state of disease, they may well be part of that discussion. And they may well agree with the doctor that, look, I'm so far along with this disease process that if I arrested, I don't want them doing all those things. Somebody like me who's experienced an awake intubation might say, I don't want to be intubated. You might want to do the other things, but you're not to do that intubation at this stage of where I am with my disease process. And those are things that can be discussed. Now, the doctor needs to discuss and tease out what that means exactly, and may say, raise the question. They said, well, I don't want to be awake intubated. What if you're not conscious? Do we intubate you then? I mean, there's a whole range of possible questions and so on that need to be teased out. If the doctor would ask those questions, or whoever's doing the advanced care plan would ask those questions to get a sense of what the patient's values were and to have that recorded. And again, the CHA, the new CHA document really prompts those questions as to what their values are on these things. So if somebody has an advanced disease process, there's something they don't want, they can be clear about it.